In this particular section, we are going to discuss on a new topic on venous thromboembolism, which is again a very, very important topic for your exams. The moment you tell about the venous thromboembolism, that is VTE, it encompasses a continuum of two important disorders that is called a DVT and a pulmonary embolus. There is also another disorder which might have similar risk factors, that is cortical venous thrombosis, CVT. Even though it's not going to come under a continuum of venous thromboembolism, we'll be discussing as a separate thing in your central nervous system topic. But right now, let us keep our discussion within the DVT and the pulmonary embolus. So, first let us look on the risk factors for developing a venous thromboembolism. Risk factors means the first thing that should come into your mind in a venous thromboembolism is going to be immobilization. That's the first thing that comes into your mind. Any immobilization for more than or equal to 3 days in the last 3 months is a very, very, very significant risk factor. So this is the top most important risk factor for developing DVT and in turn a pulmonary embolism. Apart from that, there are some exceptions are there where long flight travels for more than or equal to 8 hours itself is a risk factor for developing a DVT and a PE. But in general, it's agreed that any immobilization for more than or equal to 3 days, that is 72 hours, in the last 3 months is a risk factor for developing a DVT, and then which could be followed by a pulmonary embolism. So how can you divide this type of DVT? Initially, as a very early student, you have to know there is something called a lower limb DVT, and then you have an upper limb DVT. Even though upper limb DVT is relatively rare, you don't really get. Lower limb DVT, on the other hand, is going to be extremely common. The most common DVT usually originates from the lower limb DVT only, which means it's a synonymous thing. DVT means it's a lower limb DVT only. It's like that only right now. It's that common. So number one, what are the risk factors? You're going to be having immobilization as a very, very important risk factor. The most important reasons for this immobilization will be a recent surgery. A recent surgery. Among all the surgeries, your orthopedic surgery, especially involving the hip and knee, with special regards to your TKR and the THR, because these orthopedic surgeries of the lower limbs, especially with regards to hip and knee, especially the TKR and the THR, is going to have a high risk for developing a DVT just because the level of immobilization in these surgeries is very high. Patients would have been immobilized before the surgery itself, and after the surgery there will be a significant immobility because it's a lower limb, they cannot walk. Apart from that, the patient would have had like your cytokine excess and all these inflammatory things that's increasing during the surgery. That is also one risk factor for getting endothelial injury, which all these things is going to accelerate your Virchow's triad in developing a DVT. So that's why the orthopedic surgeries, especially of the lower limb, involving the knee and the hip joint, is one of the very, very important risk factors. Apart from that, other surgeries also have risk factors like some major abdominal surgeries and neurosurgeries. All these things do have risk factors because neurosurgeries, the patient will be in an altered mental state for a variable period of time before as well as after the surgery. So that's why it has a risk factor as well. So then major trauma. Major trauma in the sense, typically I mean a polytrauma or especially a lower limb trauma. Lower limb trauma. Clear? So this is again one of the important risk factors for developing a DVT and a PE because of the immobilization. Because polytrauma and the lower limb trauma again is comparatively going to have a higher risk of immobilization for a longer time compared to the upper limb trauma or other areas trauma, where the patient will be mobilized faster. Then, as I told you before, your long flight travels, that is also going to carry a very, very significant risk for developing DVT, especially if your flight travels exceed more than or equal to 8 hours, is really, really, like a risk factor for developing a DVT. We have picked out a lot of cases because our hospital used to have a tie-up with the airport. So what really happens is sometimes these foreigners who reach the airport suddenly get a breathlessness. So immediately the moment they get the breathlessness, they shift to the hospital and we examine. There'll be absolutely no signs. Everything will be all right. but the patient will be telling of significant breathlessness. And this is a very common scenario, especially with the foreigners. I don't know why it doesn't happen with the Indians. Maybe they tend to move a lot around, I think. But foreigners, especially when they come, we have diagnosed a lot of cases of pulmonary embolism. We straight away shift to CTP, and the CTP will show some subsegmental or a segmental thrombus. So, it's a very common scenario. So it's not something very rare. And usually this long flights, more than 8 hours, is a risk factor for those who are traveling in the economy class, because they are the ones who keep the legs shut in a very small space. And those who are in the business class, those who are traveling in the business class, usually does not have this much of immobilization because they tend to move their legs around. So that is why this type of development of DVT and a PE or venous thromboembolism after a long flight traveling in economy class is also referred to as economy class syndrome. Cool. So these are some of the important significant risk factors. But apart from that, one important risk factor I want to tell, that is a previous history of DVT and pulmonary embolism. This risk factor is supposed to be the risk factor with the maximum risk of developing a DVT and a pulmonary embolism, recurrent DVT and a pulmonary embolism, because the reason is previous history of DVT or pulmonary embolism or any venous thromboembolism would have damaged the endothelium and damaged the veins in that area. So by virtue of the endothelial injury is a definitive risk factor for developing venous thromboembolism. That is the reason why the previous history of DVT and a pulmonary embolism carries the topmost risk for developing a subsequent DVT and a PE. Very, very important point. Number 3, it's important even more than immobilization. I mean, whether immobilization is not there is a different thing. In the first attack, immobilization plays a major role. But if the patient has a previous history of DVT and PE, next time your eyes should always look for a DVT and a PE, because subsequently you have a very, very high risk factor. Apart from that, elderly patients, more than 50 years themselves, because again of immobilization, they have risk factor. Pregnancy and postpartum period. In pregnancy and postpartum, a lot of things contribute. You have venous stasis because of the gravid uterus compressing on the veins. The movement of the blood into the heart is very slow from the lower limbs. Apart from that, pregnancy itself is a hypercoagulable state. Everyone knows that. Pregnancy and postpartum period. Apart from that, there is some amount of immobilization during pregnancy, labor, and the postpartum period. So all these things are going to contribute to the development of DVT and pulmonary embolism in these cases. Then you can get with oral contraceptive pills, OCPs, and typically it's associated with exogenous estrogen use, a definitive risk factor. Apart from that, your malignancy is a definitive risk factor. Whenever you get unprovoked, without a reason, the patient comes with a DVT, no history of immobilization that much, patient comes with a DVT, especially in an old age patient, think about your cancers as a probable underlying etiology. Clear? Malignancy. Very, very important cause, especially in elderly who's coming with unprovoked DVT. So what malignancy tends to be commoner at the time of diagnosis? So a lot of malignancy, a lot of studies are telling different data. My question is, what is the malignancy that is usually common just by your numbers, mathematical percentages and numbers, when they come with the new fresh venous thromboembolism? Typically the lung cancer, obviously this is the most common cancer, right? So the lung cancer followed by the pancreatic cancer. So these are the two common cancers that usually is seen in a patient presenting with an unprovoked first DVT, especially if it's an old age patient. So this is something you have to remember at the time of new VT. So then you have hereditary thrombophilias. A lot of thrombophilias are there. You have hereditary as well as acquired. We have seen about thrombophilias in our hematology section itself. One of the most important thrombophilia is factor V Leiden mutation, and that's going to be the most common thrombophilia in the world as well. Acquired, you're having Aplar syndrome. Clear? So then you have a lot of other causes that can produce, like your myeloproliferative neoplasms. Then a lot of autoimmune disorders we already discussed, including Aplar syndromes, autoimmune disorders predisposed to hypercoagulability. Because of that, you're going to result in venous thromboembolism. Then your CVA, stroke. That's what I mean by CVA, cerebrovascular accident, stroke. Especially the first 3 months post-stroke, after the stroke, is going to have a very, very high risk factor for developing a DVT, first 3 months. And especially, you obviously know the DVT is going to be developing in the hemiparetic limb only. As simple as that. And many acute infections, morbid infections, severe infections acutely can result in immobilization and DVT. Obesity, definite risk because of immobilization again. Then you can get with popliteal cysts. These are very rare causes. Popliteal cysts are otherwise referred to as Baker's cysts, synovial protrusions. These can expand and compress on the nearby vein, resulting in stasis and DVT formation. Upper limb DVT, you don't have these many causes because it's relatively very, very rare in the first place. Upper limb DVT is also referred to as something called a Paget-Schroeder disease. It's also referred to as a Paget-Schroeder disease, Schroetter. I think my spelling is right. I'm not very sure though. Tetter. Okay. So this is Paget-Schroeder disease. So what is the most common cause for upper limb DVT? As far as you know, is the central lines, the central venous catheter. So central venous catheter, or maybe, anything, any wire or any other foreign material that is passing through the central veins. Maybe not only a central venous catheter, it could be a pacemaker lead. It could be a chemo port. Like chemo port is very often used in hematological malignancies or any other patients who are receiving palliative chemotherapy. So chemo port is a very common thing. So these are the usual and most common reason for getting an upper limb DVT. Apart from that, cancer can produce an upper limb DVT. We have seen a recent patient with a stomach cancer having a sudden onset limb swelling, developing up. When we examined with the ultrasound, we found out it's an upper limb DVT. So common, especially the GA adenocarcinomas, because they have high risk of hypercoagulability in gastrointestinal adenocarcinomas. Then thoracic outlet syndrome, very, very rare. Then finally, you have a disorder called effort-induced thrombosis. Effort-induced thrombosis, especially when your arms are engaged in extreme activity, like extreme kinds of sports, like this jabbing and all these things is going to have a high risk of DVT relatively, clear? And jackhammer operation, that's why I told you, when you're operating a jackhammer, because your endothelium might become injured because of the vibrations, and that could be the reason. This is called effort-induced thrombosis, very rare entity, but still relatively high risk. So these are some of the causes of upper limb DVT, clear? Now let us see on the pathophysiology of the entire venous thromboembolism. Pathophysiology of entire venous thromboembolism is going to be relatively simple because we are going to deal with your virtuous triad. So what virtuous triad is going to tell you is 3 components. We know that already right from the second year. You have endothelial injury or endothelial damage. You have venous stasis of blood, and that will happen in the veins for sure. Then you have hypercoagulability. Hypercoagulability. Okay, tell me some examples where endothelial injury is going to be the reason for developing a DVT. Some examples. As I already told you, the first one is the prior venous thromboembolism. Very, very high risk because of the endothelial injury only. Then trauma, surgery because of acute phase reactants and cytokines, central venous catheter, all these things are some of the examples of risk factors due to endothelial injury. Some of the risk factors due to venous stasis, typically immobilization, especially bedridden patients, development of cerebrovascular accident, maybe surgeries, long flight travels, all these things are common to immobilization. That's a significant risk factor for this venous stasis. And what about hypercoagulability? Hypercoagulability wise, you can get with different kinds of things, but very commonly you can get with thrombophilias. Lot of thrombophilias are there. Let me tell you some important thrombophilias, even though we have already discussed. You have increased platelet addition. Best example for this is heparin-induced thrombocytopenia. Then some acquired causes are there. like your autoimmune disorders, which increase the hypercoagulability. Then you have oral contraceptive pills, hormone replacement therapy, having estrogen, a little bit of increased risk of hypercoagulability, and tamoxifen again. It is similar to using a HRT, just a modified one, that's all. So selectively it acts on certain receptors, isn't it? So these are some of the important reasons for developing a hypercoagulability. And what about the thrombophilia? The thrombophilia, you have a lot of thrombophilias. I told you the most common being the factor V Leiden mutation. Clear? It's relatively rare in Indians, but very common in white population, this factor V Leiden mutation. But even though it's the most common in the entire world, but in general it's rare in Indians, but very common in whites. That too, it's said that almost 5% of the whites are heterozygous for this mutation. 5% of the whites are heterozygous for the mutation. Clear? So these heterozygotes generally don't have that much risk, even though they have a little high risk compared to general population, but they don't have that much risk like that, so they're going to present recurrent DVT and PE. But homozygotes, definitely yes, those who definitely have the disease, those homozygote population are harboring both the genes abnormally, definitely they're going to develop the disease. Then apart from that, you have other mutations are also there, like prothrombin 2021-0A mutations. This is a prothrombin gene mutation. Simply you can remember as prothrombin gene mutations. Otherwise, you have antithrombin 3 deficiency, then protein C and protein S deficiency. Remember, this factor V Leiden is also autosomal dominant, and this antithrombin 3, prothrombin gene mutation, protein C, protein S deficiency, these things are also autosomal dominant. In that, I already told you how protein C deficiency would present. Protein C deficiency is going to present like warfarin-induced skin necrosis very commonly. Remember, when you give a warfarin and patient presents with skin necrosis as the next feature, please think about protein C deficiency. The next thing, if they ask you what you want to do a protein C levels. Let me show you this. So this is one characteristic picture of a warfarin-induced skin necrosis. This patient has been given warfarin recently, 3 to 4 days ago, and the patient presented like this. This is what we refer to as warfarin-induced skin necrosis. Your kidney problem, that is called calciphylaxis, that also is going to look similar to this only, but this, in the context of warfarin, you have to diagnose it as warfarin-induced skin necrosis. Then let us move on to the DVT per se. Till now, we have seen the general risk factors of venous thromboembolism. Now, let us see the DVT per se. So, first, what are the types of DVT and how you classify a DVT based on its anatomical location? First one, you can tell whether it's a proximal DVT, or second one, you can tell it's a distal DVT. So, when you call it a proximal DVT, so if the thrombus is present in or above the popliteal veins, so popliteal vein is the landmark. Popliteal veins. Remember, if the thrombus is located in the popliteal veins or above the popliteal veins, that is called a proximal DVT. Clear? What are the veins that are above the popliteal veins? Typically, you have the femoral veins and iliac veins. Please do remember the fact that more and more the DVT is proximal, like more and more it is in the femoral or iliac, there is a very, very high risk of developing a pulmonary embolus. You have to be very sure about that. Distal, you know very well, definitely the thrombus is located distal to the popliteal veins, and it should not extend to the proximal. It means isolated distal means it's distal only. It's only present in the veins that is below the popliteal veins. That's all. So which means they will involve only the calf veins. They're going to involve only the calf veins, nothing else. Okay. Among this, obviously, as I told you, the most dangerous is going to be the proximal DVT only. The more and more proximal, more and more is the chance of pulmonary embolus, and more is the risk of death due to pulmonary embolus also. Clear? So especially DVTs, those involve the iliac veins or even the IVC sometimes are going to have the highest risk of death than pulmonary embolism. So then clinical features. Let us see the clinical features of DVT. Obviously, remember one rule of 50s are there where 50% of the DVTs will be asymptomatic. You don't even know. 50% of the DVTs will be asymptomatic. So then 50% of the DVTs will be symptomatic. That means, but these 50% of the DVTs that are having symptoms will have asymptomatic PE. In those, 50% will have asymptomatic pulmonary embolism, which means already you have developed a pulmonary embolus, but just it's very, very silent and does not cause any problems yet. That's all. 50% asymptomatic, 50% symptomatic. In those who are having 50% symptomatic DVT, 50% will have already PE that is established, but they won't be asymptomatic. That's it. So if they are symptomatic, what is going to be the most common symptom? Most common symptom is going to be the swelling. Swelling is the most common symptom and as well as the clinical feature, especially a swelling that is asymmetric. Especially if it's asymmetric by more than or equal to 3 centimeter, there is a very, very, very high risk of that swelling being a DVT. So that's why this asymmetry of the swelling is a very important feature again. Then you can see some signs of inflammation also in the local area. Again, which are very non-specific, but still this temperature and redness in the local area, and again are like very common in patient with a DVT. And very importantly, you can see one sign called the livedo reticularis. This livedo reticularis is a type of a rash which has a fishnet kind of an appearance. It's a lazy pattern, and it is due to dilation of the venules, due to obstruction of the veins, or thrombosis of the capillaries of the veins. So whatever may be the reason. So, but livedo reticularis you're going to encounter more in a patient who's having a vasculitis than like in this DVT. But still, livedo reticularis has been described in patients who are having a long-standing chronic deep vein thrombosis. So these patients may have a livedo reticularis type of a rash. Clear? Fine. So next, you can have a lot of examination findings in DVT. But before going into the signs per se, I have to tell very clearly one thing, but these signs are neither specific or not sensitive for diagnosis of a DVT. At the same time, doing these signs itself, performing this test itself might result in a dislodgement of the clot and formation of a pulmonary embolus. So be careful, and these signs are really not recommended in your routine clinical practice because they are not helpful. At the same time, they might be harmful also. But anyway, just for the sake of exams, we are seeing these signs. The first one I'm going to show is this one. This is the moment you see this, you have to answer this. This sign is what we refer to as something called a Hohmann sign. Hohmann sign, right? So what I'm doing here, I'm trying to forcibly dorsiflex the ankle. So dorsiflexing the ankle is going to result in pain at the calf. So this is what we're going to call as Hohmann sign, and sensitivity is typically less than 5%, as I already described. And if you see this, again, you should be able to find out what this sign is. This sign is what we refer to as the Moses sign, otherwise called as Bancroft sign. So what do you mean by Moses or Bancroft sign? You're trying to squeeze the posterior aspect of the calf, and which is going to create a pain. So this is what we refer to as Moses sign or Bancroft sign. So these are the two signs that you have to know importantly, but apart from that, there are a lot of other truckload of signs that are there, which are really not important for exams. Number one is your Pratt sign. So how will you do the Pratt sign? You ask the patient to be in the prone position, then take the leg and squeeze both the calves. At the same time, give pressure on the popliteal vein on the proximal aspect also, and this will create a pain, and this is what we refer to as Pratt sign. And next, you have Lowenberg sign. This is a very trivial of all the signs, where applying a sphygmomanometric cuff and elevating the pressure in the sphygmomanometer around the leg will elicit pain. Very simple, very trivial, very funny and very silly also. This you can do it in the Moses sign as well as Pratt sign itself. Then you have a Neuhoff sign. So where if you press the calf in this, you will appreciate deep pain, fine. At the same time, the calf muscles will be thickened also. That is because of edema. So this is what we refer to as Neuhoff sign. Then you have Linton sign, which you generally do for varicose veins also, where you tie a tourniquet at the saphenofemoral junction and ask the patient to walk a little bit, and then you lift the limbs up, affected limb up, and you will see dilated superficial vein. So this is what we refer to as Linton sign, and very, very less specific, can be seen in patients who's having a simple varicose veins itself. So this is what we refer to as Linton sign. So these are some of the signs that are not important. Then we'll see what are the severe signs. There are 2 severe signs are there, and these severe signs generally happen with proximal DVT very often, and these patients will be having impending gangrene most of the time. So which means you have to intervene urgently. As soon as possible, you have to intervene urgently in these patients. So what are the signs, severe signs that happen due to massive proximal DVT? One is called phlegmasia, cerulear dolens, and the second one is phlegmasia alba dolens. Cerulear dolens is quite common compared to the alba dolens, where the limb will be blue and cyanotic. And a lot of edema will be there. In compared to the alba dolens, where the limb will be white in color. That's why it's called alba. So let us see the image. So this is what we refer to as phlegmasia cerulear dolens, where you can see the entire limb is cyanotic. That is usually due to a massive proximal DVT that is going to obstruct the entire venous return from that particular limb. And you can see the vein is lot edematous, and these patients are going to suffer from a serious pain, and this edema itself may progress to compartmental syndrome, and this compartmental syndrome may progress to gangrene. So that's why you need a immediate treatment in these patients in the form of either a catheter-directed thrombolysis or even a thrombectomy is advocated by some vascular surgeons, but this need to be intervened as soon as possible. And you can see this is a simple DVT on the left side. You can see in image number A, where you can see this limb is definitely swollen and it is erythematous. Sure, there is no doubt about that. And this is one of our young patients who came with a sudden onset right leg swelling. He just came with that. There is no history of immobilization. It's unprovoked. No background history is there. And we took a Doppler for this limb, and it came out as a deep vein thrombosis. And what do you think? A 28-year, 29-year young patient, unprovoked DVT, without any background history of any risk factor, suddenly coming with DVT. You're going to think about thrombophilias as a very common possibility, because young patient, unprovoked, think about thrombophilia. Old patient, unprovoked, no background history, sudden DVT. Old patient, think about a cancer coexisting. This is what we categorize: unprovoked young, thrombophilia; old, unprovoked, cancer. But I'm not telling these are the only possibilities, but very probable. This is what you're going to find out. Okay. Then we are in the stage of achieving a diagnosis through investigations. And what are the investigations to do, and how will you achieve a diagnosis? All based on a famous score called Wells score for DVT. Because you have the Wells score for PE also, pulmonary embolism also. So that's why I specifically told you this is a Wells score for DVT. And what are the points that you have in the Wells score for DVT? And these are the points. So even though this looks a bit clumsy, let us organize it. So the first one, the active cancer history, and probably another history, previous history of documented DVT, both carry 1 point already. In fact, everything in this table carries 1 point. But let us put this under a common conundrum, like this will be put under medical history. So medical history has 2 things. One is active cancer and previous history of a DVT or a pulmonary embolism or any venous thromboembolism. Active cancer, they have defined that also, where they have received treatment in the last 6 months, or they are already undergoing treatment, or those who are receiving a palliative care right now. So this is what we call as an active cancer by definition anyway. So these are the two things that carries 1 point in the Wells score. And apart from that, certain other things you can categorize, like this calf swelling more than or equal to 3 cm compared to the asymptomatic calf, which means I already described about that asymptomatic calf swelling 3 cm above, very high risk. Then you have this swollen unilateral superficial veins, which is non-varicose type in the symptomatic leg, and unilateral pitting edema in the symptomatic leg. Then swelling of the entire leg or localized tenderness along the deep venous system. So this 5 points, 1, 2, 3, 4, 5, each carry 1 point, all right, but all this can be put under a common conundrum called clinical symptoms. So these are the clinical symptoms. So then you have 2 points which point about immobilization. So these points you can put under a common thing called immobilization history. Clear? Anything more than 3 days for more than 3 months is very, very significant. Clear? That is what we hear, it's put as 12 weeks, 3 months. Then alternative diagnosis is at least as likely, which means you have an alternative diagnosis that can explain the edema. Simple example. Let me tell you, a patient is a diabetic patient and is coming with a high grade fever and sudden onset swelling of the right lower limb. And what do you think there? I will think of cellulitis as a first possibility, even though DVT can be there. I'm not telling no, DVT can be there, but my cellulitis is the first possibility. So if you have alternative diagnosis as a first possibility, apart from DVT, the score will be degraded by 2 points, which is a -2 point, which means it goes against DVT. That's why. So the total score, you can see it's going to be 1, 2, 3, 4, 5, 6, 7, 8, 9. Maximum score is going to be 9 and minimum score is going to be 0. So you can tell the points are going to be 0 to 9. In that, if you have a score of less than or equal to 1, we can tell DVT is highly unlikely. If the score of more than or equal to 2 means, in this condition, DVT is extremely likely. High risk for DVT. Any score of more than or equal to 2. So this is how we are going to evaluate. So how we are going to evaluate? Let's put an algorithm. So first one, see the Wells score. If the Wells score is going to be more than or equal to 2, you know that the DVT is likely in this patient. Or if the Wells score is less than or equal to 2, you know that the DVT is unlikely in this patient. Clear? So whenever the DVT is unlikely and the Wells score is low, which means actually you're trying to rule out a DVT, which is just a possibility here. But here, if the DVT is likely, means you're trying to make a diagnosis of a DVT. The score of more than or equal to 2 means it's a high risk and you're trying actually to find out a DVT where the possibility is more than just a possibility. So that's how you have to understand. So if the DVT is unlikely, you're just trying to rule out. So what is the best test to rule out a DVT? D-dimer. So this is one of the best tests to rule out a DVT because this D-dimer is going to have a very, very high negative predictive value, which means literally around 98 to 99% NPV, which means if the test is negative, it's going to definitely rule out the condition. That's what the idea is. And it's going to have an extremely high sensitivity, around 95%, but it still suffers from a very low specificity of only 60 to 70% because this elevation of the D-dimer may be seen in many other conditions also. So if the test is negative, I can concretely rule out a DVT. But if the test is positive, I cannot confirm a DVT. That's the problem. So if the DVT is likely, what you will be doing? If the DVT is likely, then I will go for an investigation called a compression ultrasound. It can also be called as a beam mode compression ultrasound. I'll tell you what you're going to look for here. So if the compression ultrasound is negative or the compression ultrasound is positive, the compression ultrasound is showing a DVT, then I can confirm it's a DVT. There's no doubt about that. If the compression ultrasound is negative for a DVT, actually, at least for exams, you can remember I can rule out a DVT. But again, depends on how you understand this compression ultrasound. Remember the sensitivity of this compression ultrasound, if the patient is symptomatic, means it's almost 99%. But if the patient is asymptomatic, the sensitivity falls to 90 to 91%, which means almost 10% of the case of DVT you might miss if the patient is having an asymptomatic DVT, which means there's no clinical features of a DVT. So that is the reason why many guidelines have told, even if the compression ultrasound is negative, but if the patient is asymptomatic, you might be needing to do a compression ultrasound after a couple of weeks, that is 2 weeks, to rule out a DVT. But anyway, for exams at least you can remember that if compression ultrasound is negative, then you can actually rule out a DVT. But at the same time, I told you this D-dimer, if it's positive also, you cannot confirm a DVT. In this instance, you have to definitely do a compression ultrasound to make a concrete diagnosis. You have to do that. So cutoff of 0.5 is what is used by majority of the guidelines. And even in India, this value is the one that is very significant. 0.5, either it's more than 0.5 or less than 0.5, the D-dimer value, that will tell you whether it's positive or negative. So this is what you're going to do. The moment you are confirm the DVT, now which means I have to treat the DVT, right? So the treatment of DVT, if they ask you what is the treatment of choice, definitely I'm going to tell it's a anticoagulation. For that matters, any venous thrombosis, the treatment of choice will be anticoagulation. That's all. You have to be very, very, very sure about this fact. That's all. But you have some like treatment protocols, which we'll see. First of all, when you are dealing with the patient with a suspected DVT, let us start from there. You know the Wells score. So it could be less than or equal to 1 or more than or equal to 2. You know more than or equal to 2 means you're going to have a high risk. Less than or equal to 1 means it's a low risk for DVT. Anyway, you're going to work up both the patients, either with the D-dimer or either with the compression ultrasound. Clear? We have discussed that already. Here, why I put plus or minus compression ultrasound? Because if the D-dimer is positive, you are going to do a compression ultrasound. So you are anyway doing a workup. But very important point, why I have told you this again, is because if you are having a high risk for a DVT, then you can actually start a empirical anticoagulation. Typical example is heparin. We most commonly start with low molecular heparin. Typically, we start with that. So if it's a high risk, even if you're waiting for the workup, there's no point. You can give the first dose of heparin and you can start the workup. There's no harm. So the workup may come as negative, which means you have ruled out a DVT. The workup may come as positive, which means you have confirmed DVT. Now, if the DVT is confirmed, now you can go for looking for the severe symptoms. So if the patient is having any severe clinical features, what do you mean by the severe clinical features? Is the fact number 1, I already discussed about this. That's called a phlegmasia cerulea dolens. And second one, we've already discussed if it's an extensive iliofemoral DVT. Almost the entire of the iliac and the femoral veins are occluded with thrombus, extensive iliofemoral thrombosis. So if you have this severe clinical features, then it's always better to go for a catheter-directed thrombolysis. It's always better to go for a catheter-directed thrombolysis. Because this catheter-directed thrombolysis is not the treatment of choice. Anticoagulation is the treatment of choice, I told you. But catheter-directed thrombolysis in patients with severe symptoms will reduce the risk of pulmonary embolus. At the same time, it reduces the risk of limb-threatening ischemia and gangrene. At the same time, it will reduce the risk of developing post-thrombotic syndrome also, which we'll be discussing in the complication. So it reduces the risk of further complication. That's why we do the catheter-directed thrombolysis here. If no, then see the site of DVT. So site of DVT can be a proximal DVT or a distal DVT. You know what is the definition of proximal versus distal? Depending on the popliteal vein involvement is there or not. Anything popliteal vein or above, you call it as proximal. Anything below the popliteal vein is not involved means it is distal DVT. Only the calf veins will be involved. Proximal DVT means definitely you have to start with anticoagulation. There is no doubt about that. And one more thing is, even after thrombolysis, you have to give anticoagulation. There is no doubt about that. Post-lysis, you have to definitely start with anticoagulation because I told you this is the main treatment in any venous thrombosis. Now, distal DVT you can split into either symptomatic or asymptomatic. Definitely any symptomatic DVT, distal DVT again will be start with anticoagulation. If it's an asymptomatic and distal DVT, then you can observe this patient with serial compression ultrasound every 2 weeks. Serial compression ultrasound every 2 weeks you can observe this patient. Suppose if the DVT is extending or increasing or extending proximally, definitely you have to start with anticoagulation. There's no doubt. If the serial ultrasound shows regression of DVT or disappearance of DVT, then no need to do anything. Just either continue observation and stop the observation over a period of time. So this is what you're going to do. This is how you treat a deep vein thrombosis. This is how you manage a deep vein thrombosis. But be very clear. If they ask you the mainstay of treatment for any deep vein thrombosis, it's going to be the anticoagulation. There is no doubt about that. Duration of anticoagulation we'll be discussing along with the pulmonary embolism section, which is in the next section. We are going to discuss the pulmonary embolism, but let us know that anticoagulation is the mainstay right now. Now, final thing about this particular video is on the complications of the DVT. So what are the complications of the DVT? Number one, obviously it's a pulmonary embolism. There's no doubt about that. It's one of the deadliest and the most important complications. Second one, post-thrombotic syndrome. That's called the PTS, post-thrombotic syndrome. So what do you mean by post-thrombotic syndrome? It happens after DVT, most commonly after your proximal DVT, then distal DVT. Most commonly after post-proximal DVT, especially if it's involving the iliac veins, then femoral veins. So the patient will be having symptoms and signs of chronic venous ischemia, symptoms and signs of chronic venous insufficiency, which means the patient will be getting pain, ulcers, discoloration, all these things the patient will be getting. That is due to chronic venous insufficiency. But if you ask me the question why they should develop a chronic venous insufficiency, what is the reason? Because this DVT will damage the valves. Because of the damage to the valves, they are resulting in features of this valvular incompetence. I mean, that is going to manifest as a chronic venous insufficiency like pain, edema, ulceration and all. So I told you already, this early thrombolysis is going to reduce the risk of post-thrombotic syndrome. That point is also important to know. If you have a severe symptom and extensive proximal iliofemoral thrombosis. So at the same time, how can you diagnose this post-thrombotic syndrome? Is by using a score called modified Villalta score. Modified Villalta score. So this score is the one, the name alone is enough for exams. So if you know this, it's more than enough. So modified Villalta score is going to be one of the very, very important scoring system to diagnose and grade the severity of the post-thrombotic syndrome. Apart from that, you might get recurrent venous thromboembolism also. I told you any prior history of DVT and a pulmonary embolus is going to increase the risk of subsequent venous thromboembolism just because of the fact that the prior VT is going to cause endothelial injury, and endothelial injury is always an idea for developing a recurrent thrombus. So these are three very, very important complications of a DVT. So we have discussed enough about DVT in this particular topic, and we have discussed about the basics of venous thromboembolism also in the same video. So now we'll close this off and we'll move on to the discussion of the pulmonary embolism in the next section.